So let me ask, just to kind of get a sense of, as an audience, kind of where we are, familiarity with knee arthritis and total knee replacement. Who here is familiar with total knee replacement, either has one or knows somebody who has one? All right. How about partial knee replacement? Familiar with that? How about computer navigation, internal, external navigation, computer-assisted knee replacement? Anybody familiar with those concepts and those terms? What I want to do today is essentially just kind of go through three basic things. One is just review knee osteoarthritis just as we would if we were in the office together. What is it? How do we know what it is? What are our treatment options? The second thing I want to review is the difference between total knee replacement and partial knee replacement. And then the third thing I want to review is some newer technology utilizing technology such as CAT scan, MRI, computer-assisted knee replacement surgery, the benefits, the risks, and just kind of introduce that and give some basic information on some of those technologies that we're utilizing. That third component can get a little bit technical, so I'll get as technical as you guys want to if you have any questions for me. But I'm just going to kind of lay it out there just as a general idea so you can kind of become familiar with what some of our options are. So first, knee osteoarthritis. What is it? There's two basic large categories of arthritis in the knee. One is rheumatoid arthritis, where the body actually attacks its own joints. That is not wear and tear osteoarthritis. When we're talking about arthritis, we're talking about the articular cartilage on the end of the bone. So if you're eating a piece of chicken, you get to the end of the chicken bone where there's that white gristle, that is articular cartilage. And that's what we're talking about when we're talking about wear and tear osteoarthritis. This is just a cartoon, a drawing of what kind of reflects normal, healthy, smooth, good articular cartilage. And on this side, we see how it's pitted, it's rough, it's worn thin. This is advanced osteoarthritis, which is just wear and tear, thinning of the articular cartilage on the end of the bone. So when we talk about osteoarthritis, this is the process that we're talking about. Now, these are just a couple of pictures inside the knee joint during a routine knee arthroscopy. This knee up here is the end of the bone inside the knee joint, and you can see how up here it's nice and white and smooth. That's good, healthy articular cartilage. Now, this picture down here, you can see how this white stuff is broken off, it's thinned, and there's even a little bit of bone showing through right here. That is wear and tear osteoarthritis. So, symptoms of osteoarthritis. Some of you may kind of identify with some of this. The main thing is pain. That's typically the most common reason why somebody who has osteoarthritis in the knee seeks treatment. Say, okay, the knee, it's misbehaving, it's hurting, it's slowing me down, I can't do the things that I want and need to do. Also, grinding, popping, bowing of the legs. As knee osteoarthritis gets worse and worse and worse, in some cases you can start to see some bowing of the legs, or you can start to see a knock-knee deformity that wasn't there before. So those angular deformities of the knee, that can also be a consequence of osteoarthritis as it progresses over time. And as far as diagnosing it, it's really straightforward. There's really two components to diagnosing knee osteoarthritis. One is, okay, how does the knee behave and how does it look like when I examine in the office? The other is plain x-rays. Those are the most useful diagnostic studies used to diagnose and measure the progression of osteoarthritis. It's more useful than MRI, it's more useful than CAT scan, bone scan. Plain x-rays are the most useful to measure and evaluate osteoarthritis. And so this is what we routinely do in the knee. Now, I like this x-ray because it kind of shows us two things. This here is the outside of the knee, or the lateral aspect of the knee. And you can see how the femur bone comes down, and there's a nice space there between the femur bone and the tibia bone. That suggests that there's nice, thick, healthy articular cartilage there. So this side of the knee actually looks very healthy right here. But this side over here, you see there's no space left. That articular cartilage has worn thin to the point that on this side of the knee, that knee joint is scraping bone on bone every time that knee is moved and every time a step is taken. So nice, healthy aspect of the knee here, scraping bone on this side of the knee there. So when we get to this point in the office, say, okay, the knee is hurting, we know what's going on, we know it's wear and tear osteoarthritis. The next logical question is, what are we going to do about it? In that situation, there's really only one of three basic options. The first option is do nothing. That's always an option. Just because osteoarthritis is inside the knee doesn't necessarily mean the knee will hurt. And if it does, it's not a dangerous thing unless it starts to get to the point where you can't control the leg and you get risk falling and breaking your wrist. That actually can be a dangerous thing. But the first option is always do nothing. The second option, try to make it feel better with no surgery. And there are a number of things that we can do to try to make knee pain from osteoarthritis feel better before we even talk about surgery. And this is always where we start. And then, of course, the third option is the cure, which is surgery. So whenever we are kind of early on in treating knee osteoarthritis, these are the kind of things that we have to choose from. Anti-inflammatory medications, I prefer the cream that's prescription strength that we rub directly into the knee rather than load the gut with a lot of oral medications. To a certain degree, one degree or another, every medication is a poison. And so every medication has the potential of causing problems, and so if we can avoid some of those problems by limiting the number of anti-inflammatories we take by mouth that can upset the stomach and cause other troubles, I prefer to use the creams if they work. So we'll oftentimes try this anti-inflammatory cream just to treat the symptoms of the osteoarthritis. Sometimes knee bracing can help. Injections, there's two different kinds of injections that can be done. One, just a simple steroid injection, decreases inflammation. There's another category of injection, which is more like a motor oil type material that coats the end of the bone, and that can be a very effective treatment for some people. Supplements, chondroitin sulfate, some of those oral supplements, my line on that is if it helps and if you can tell a difference, there's value there, continue to take it. I have a lot of people who take it, can't tell that it's making any difference, but they take it in hopes that it's going to do something. The beneficial effect there is just the anti-inflammatory effect. So if you're taking chondroitin sulfate and glucosamine and it makes the knee feel better, continue to take it. If you're taking it but you can't really tell any difference if you miss a week or two, then it's probably not worth the money. And then activity modification, low impact exercise. I discourage the high impact exercises. So my patients who have advanced osteoarthritis but still love to get out and run 5 miles a day, I try to talk them into different modes of activity because that's just making the knee angry. And also low impact exercise such as stationary bicycling, swimming, that low impact exercise can actually help to diminish some of the symptoms of osteoarthritis. So this is always where we start when we're talking about treating knee osteoarthritis is let's start with the simple stuff first. Now of course, if we do these things, but the osteoarthritis and the osteoarthritis pain is so advanced that none of these things are helping, then we start talking about the cure. So these are the last two categories I want to review briefly with you. The basic difference between a total knee replacement and a partial knee replacement. And let's start there. So this is an x-ray of a patient from my practice who has tried all the non-operative things, but these x-rays are pretty significant, which reveal pretty significant osteoarthritis. So on both sides of the knee joint here, there's just scraping of bone on bone. There's big joint spurs here. And you can kind of get a sense from this x-ray that this knee is also starting to bow this way. And so all of these are the consequences of knee osteoarthritis. And in this patient, it got to the point that it was very, very difficult to walk, even with a walker. And so that is a picture of the knee after joint replacement surgery. And by replacing this joint, literally what I'm doing is giving the joint itself a new surface. So rather than scraping bone on bone, there's a nice new metal and plastic surface. There's a plastic insert between these two metal components that you can't see on the x-ray. And so by changing that surface from bone on bone to metal on plastic, it diminishes and actually eliminates the osteoarthritis inside the knee. And you can see also, well, you can't, I'll show it on the next one, that it also can correct, and part of the procedure is to correct any alignment, any bowing of the knees or any knock-knee deformity of the knees. So after total knee replacement, typically 2 or 3 nights in the hospital, and the majority of my patients go home with home health after they leave the hospital. On occasion, it is wise to arrange for a short stay in a rehab facility, but most people can go home with a visiting nurse and a visiting therapist that can check on them at the house after they go home. I encourage people to use this walker. A walker is very important initially just for safety because it's kind of hard to control the leg at first because it just had big knee surgery done. So a walker for somewhere between 2 to 4 weeks is pretty routine, just for safety purposes until the knee is feeling better and the strength is returning where the patient can get around safely. Full recovery is really 4 to 6 months for most people. Now, everybody bounces back at their own pace, but a continued experience of improvement in swelling, improvement in range of motion, strength, and getting around, that's a process that's somewhere in the ballpark of 4 to 6 months. And a lot of times I'll say people, really, it's a 1-year healing experience, but most of that improvement is in the first 6 months, and most of that improvement's in the first 3 months. And if you were to put all the studies on total knee replacement all together and look at success rate, the number that you kind of end up with is a 90% success rate at 10 years. Meaning that 10 years after the surgery, if you were to take 100 people who had them done, 90 of them would still have a knee that feels good and is functioning well. Now within that first 10 years, about 10% start to have problems for one reason or another that in many cases leads to the point where that knee has to be revised. But that's kind of the overall kind of average number when we're talking about a 10-year success rate for total knee replacement. Now with some of the advances that we have in techniques and with materials, we are seeing more and more 20-year knees that are still working well. But when we take all comers, this 90% is still kind of the average. Okay, and so here this is, that's total knee replacement. You can see the angular deformity here, the bowing. Not only was the arthritis taken out of the knee, but the angle of the knee was restored to a more normal angle as well. So that's what most people are familiar with, is total knee replacement. Okay, so let's go to the other possibility, partial knee replacement. For many, many years, partial knee replacement was frowned upon because for some people it worked great, but it started to fail within 5 years or so. So most surgeons kind of came to the idea that, well, if it's only going to be a 5-year solution and you're going to have to go back and have the whole knee done anyways, let's forget the partial knee and just go straight to a total knee replacement. And with the options that we had available at that time, definitely in the 70s and early 80s, that was probably the right answer. So partial knee replacement kind of fell out of favor for a number of years. And that gets back to the design of the partial knee implant. About 22 years ago in Oxford, England, there's a group of surgeons that developed a partial knee replacement that was different from all the others. And what is different is there are 3 components here. So it's just replacing the articular cartilage in only part of the knee, not the entire knee. And so again, it's metal, plastic, and metal, but this aspect of the knee, if it is natural and healthy, it allows us to have that portion of the knee that's natural and healthy remain natural and healthy and replace the arthritis where the arthritis is. But this plastic piece right here is a plastic insert in between those 2 pieces of the middle that floats freely. And that allows that knee range of motion and that knee to function more like a natural knee. And so it kind of gets back into the biomechanics of it. So about 22 years ago, this group started to do the partial knee replacement in Oxford, England. And they followed their results over 22 years. And if you look at the difference here, going back to this x-ray where this portion of the knee looked natural and healthy, but here scraping bone on bone. And this is that knee after a partial knee replacement surgery. There's a number of considerations when we're talking about partial knee replacement. One is it's a much smaller incision, so it's less insult to the soft tissues of the knee, which leads to a quicker recovery. And all of that's very good, but what they found is this, a 98% success rate at 10 years. And they now even have 20-year data that shows a 92% success rate at 20 years. And so by this design, they're getting results at 20 years that are much, much different than what we've seen with all of the other designs which have the piece of plastic that's fixed to one of the pieces of metal. So these results are much, much different. Quicker recovery, typically 1 or 2 nights in the hospital. I have had patients go home the same day from surgery, and those who are, who are strong and have a good support system, sometimes that's appropriate. Usually I'd like to talk people into staying at least 1 night in the hospital just to make sure the pain's controlled, nausea is controlled, make sure they get up and they're safe to go home. But this can be done even as an outpatient in some people. Typically 1 or 2 weeks on the walker. It's routine that we'll have somebody come back for their 2-week check to check the wound, and they're walking independently without a walker. That's not everybody, but that's not uncommon. So it is a quicker recovery. And in the United States, The FDA approved this device to be used in 2004, and all of our early data since 2004 is matching the 20-year data in England. So I do believe that this option really is unique. And so again, looking at them side by side, just looking at the x-rays, that's the difference between a total knee replacement that replaces all compartments of the knee, the lateral compartment, the medial compartment, and underneath the kneecap, versus just replacing one portion of the knee.